Hi, I'm Dan Reznicek from Pacific Northwest Urology Specialist in Bellingham, Washington, and today I'm going to be going over treatment options for clinically localized prostate cancer. I've made several other videos recently that go over the basics of prostate cancer and how to figure out what risk group you have. This video is going to go over the specific treatment options that are currently recommended for clinically localized prostate cancer from the National Comprehensive Cancer Network. We're going to go over the three major treatment options today of active surveillance, radiation, and surgery. And we're going to compare each one and the risks of each option. And then we're going to talk about some of the trials that cover the long-term risks of these procedures. So to review, we're going to be using the 2025 National Comprehensive Cancer Network guidelines for prostate cancer. These guidelines are put together by a combination of urologists, radiation oncologists, and medical oncologists who treat prostate cancer, and these guidelines are evidence-based. When we talk about localized prostate cancer, we are referring to prostate cancer confined to the prostate or immediately outside the prostate. The goal for all of these treatments is generally to try and cure and remove all the cancer. This is different from advanced prostate cancer, where the goal is to treat the prostate cancer or slow its growth. For advanced prostate cancer, too many cells have escaped the prostate itself to target all of them and hope for a cure, and we're trying to slow it down. For localized prostate cancer, the current recommendation for treatment include active surveillance, surgery, and radiation therapy. So first, let's discuss active surveillance. First off, sometimes the terms active surveillance and watchful waiting are used in this scenario, but there is a significant difference for us between these two definitions. And it's important to differentiate the two when discussing your goals. This can be confusing. I've even seen urologists use these interchangeably, but specifically, active surveillance involves closely monitoring the cancer with the goal is to treat that cancer for potential cure if the cancer progresses at a later date. This is like delayed treatment. For these patients, the risks of treatment right now outweigh the benefits. But if the cancer becomes more aggressive later, we're going to treat it at that time. Observation or watchful waiting is different. Observation implies less aggressive monitoring and only treating the cancer if symptoms develop or are thought to be imminent. This means that the goal for observation is not necessarily a cure because life expectancy may be shorter than the expected growth rate of the prostate cancer. Observation will let the cancer spread beyond a curative point, but then treat it if it's going to start causing symptoms like difficulty voiding or back pain. These are quite different goals, right? One is for cure, and one is only treat if it's causing problems. It is important to note we did not always have active surveillance as a treatment option for prostate cancer. Early on, when we first discovered PSA testing, men who were diagnosed with cancer were often treated unless they were too unhealthy. In the 1990s, up to 80% of patients underwent treatment when diagnosed with low-risk prostate cancer, and only 20% had expectant management. However, in the early 2000s, studies started demonstrating that surveillance could be a safe option for many men with low-risk prostate cancer. These early studies only included men with what would now be called very low-risk prostate cancer. For example, in this study from Johns Hopkins, only 1% of all their prostate cancer patients were enrolled in the study. They had to have clinical T1C disease, Gleason grade group 1 prostate cancer or less, and no more than 2 cores positive, and of those cores, no more than 50% of 1 core positive with cancer. In these early studies, men had surveillance biopsies every single year. These early studies showed that the rate of advanced prostate cancer developing on surveillance for low-risk prostate cancer was very low. Follow-up studies confirm the results. In these studies, 50 to 60% of the men avoided treatment altogether for up to 10 years. And when they got treatment, they didn't have worse outcomes. All of the studies for low-risk prostate cancer have very good long-term survival, with prostate-specific survival of 98% or higher. Of note, not many of these studies included intermediate risk patients on surveillance, other than this one study from Toronto. The progression to advanced disease was low in the low-risk prostate cancer patients and was less than 1% in all of the groups except for the Toronto group. In that group, the intermediate risk prostate cancer patients had a 6.6% chance of progression to lymph node disease or metastasis. Now, each of these studies had slightly different surveillance recommendations and follow-up strategies. The NCCN, or National Comprehensive Cancer Network, provides some recommendations on how surveillance should be done. First, after being diagnosed with prostate cancer, for those on active surveillance, the NCCN recommends confirmatory testing of the cancer to be performed within the first 6 to 12 months of diagnosis to confirm that the cancer is not becoming more aggressive. They do leave a few other options here, including a repeat biopsy, MRI of the prostate, or molecular testing. If the MRI or molecular testing confirms less aggressive disease, they recommend all patients undergo a repeat prostate biopsy between 1 and 2 years after the initial diagnosis. This is recommended even if your PSA is unchanged and your MRI is unchanged, as the initial prostate biopsy may underestimate tumor grade or volume. Other key items in active surveillance include periodic PSA testing, digital rectal exam, and repeat prostate biopsies. The NCCN recommends doing a PSA no more often than every 6 months, repeat MRIs no more often than every 12 months, digital rectal exams no more often than 12 months, and repeat biopsies no more often than every 12 months unless there's a significant clinical change. Increasing the interval of testing beyond what the recommendations show does not appear to improve outcomes in clinical trials. All right, so when does active surveillance end? When on active surveillance, we stop surveillance if the cancer progresses, if the patient desires treatment, or if the life expectancy of the patient decreases. In the last case, we would move from surveillance to observation. All right, what are the benefits of active surveillance? The benefits are that the large portion of men will avoid treatment and the risks of treatment for a significant time period. If we can delay the treatment for several years, men will have fewer years with side effects that could be with treatment, such as erectile dysfunction or incontinence. For many men, waiting and treating later does not worsen the outcome, and some men may avoid treatment altogether. The risk of active surveillance is that a small percentage of patients may miss that window to cure the cancer while on surveillance. Progression to regional or metastatic disease is rare. Most studies showed under a 0.5% risk. The caveat would be the studies with intermediate risk prostate cancer. All right, let's transition and talk about one of the other main options for prostate cancer, radiation therapy. In general, radiation uses high-energy particles like X-rays or gamma rays to damage or kill cancerous cells. Radiation can be given different ways, but in each method, these high-energy particles hit the cells and damage part of the cells. Radiation causes double-stranded DNA breaks, and if the cell is unable to repair itself, it will die immediately, or when it tries to replicate in the future, it will have too much damage and die. Radiation can be given with two different methods, either internally placed radioactive seeds that are placed throughout the prostate, or external beam radiation therapy, where only X-rays go through and you are targeting the cancerous cells. With external beam radiation therapy, the beam is created outside the body and targeted internally, and the patient is not radioactive. There are a variety of ways that external beam radiation therapy may be given. It may be given with traditional photons, which are small particles like X-rays, or as you may have heard from advertising, proton beam radiation. Proton beam radiation is also external beam, but uses much larger particles, protons, for radiation and requires a larger proton accelerator. And we'll get into more of that later. In brachytherapy, the radiation dose is given directly to the prostate itself with needles and small seeds placed in the prostate. There is another method, one which involves tubes placed in the prostate and high-dose radiation given directly, but that's less common these days. The more common method for brachytherapy is radioactive seeds placed within the prostate that emit radiation over a period of time. The benefit is a high dose of radiation with a small fallout. A high percentage of the radiation stays very close to the seeds and avoids other surrounding target tissue. The procedure to place brachytherapy seeds is generally done under a general anesthetic and involves mapping of the prostate carefully with an ultrasound to carefully place the seeds to ensure an effective dose of radiation gets throughout the prostate. Brachytherapy can sometimes be difficult to perform if the prostate gland is very large, very small, or if there's other anatomical problems. Additionally, for higher risk patients with prostate cancer, brachytherapy alone is generally not performed, as the radiation dose does not effectively treat the seminal vesicles behind the prostate or the lymph nodes. But for these patients, if they want brachytherapy, we can combine it as well with external beam radiation therapy to treat the other locations. And this is sometimes called a brachytherapy boost. All right, proton therapy. Proton therapy has been around for a long time. It does require a large proton accelerator, which are not available everywhere. Theoretically, proton radiation will deliver less radiation to surrounding normal tissues like muscle, bone, fat, which are not immediately next to the prostate. In other cancer locations in the body, proton therapy has been found to have lower side effects compared to standard radiation. However, thus far in prostate cancer, many clinical trials have been performed, and there does not seem to be a significant difference in terms of early toxicity or side effects at up to 2 years. In the largest retrospective analysis to date, when comparing standard radiation to proton radiation therapy, those who received standard radiation therapy had lower GI side effects and otherwise similar rates of urinary complications or sexual side effects. So although there's a lot of advertising around proton therapy, there doesn't seem to be a large improvement in symptoms. The one thing that has been shown consistently with comparing proton therapy to photon or normal standard radiation therapy is that proton radiation therapy is quite a bit more expensive. Again, this is because it requires a much larger accelerator and is at least 2 times the price of standard radiation therapy and may not be covered by your insurance. All right, on the topic of radiation therapy, it's important for us to talk about hormone therapy. For some patients who are receiving radiation, studies have shown that receiving hormone therapy during radiation has improved outcomes. Hormone therapy is not recommended by itself for the treatment of localized prostate cancer because it does not kill the cells, but for radiation it appears to have a sensitizing effect. It starves the cancer of this growth factor and makes the radiation more effective. In patients with higher risk disease, multiple clinical trials have shown improved overall survival and biochemical recurrent free survival with hormone therapy. What is hormone therapy? Hormone therapy for prostate cancer involves lowering your testosterone levels significantly, down to what we say are castrate levels. It basically blocks your testicles from making testosterone. This hormone therapy does come with risks, including sexual side effects such as decreased libido and erectile dysfunction. It may have other non-sexual side effects as well, such as fatigue, mood changes, decreased bone strength, decreased muscle mass, and increased risk of heart disease. The risks of hormone therapy are generally worse the longer you're on the medication, and it may take longer to recover your testosterone production the longer you're on it. In some men, they will not recover to normal testosterone levels even after stopping these medications. For the treatment of localized prostate cancer, the use of hormone therapy is unique to radiation, and there's been shown to be no benefit to using it with surgery. All right, so let's move on and talk about the risks of radiation. The risks of radiation therapy are generally due to the high dose of radiation that affects the tissues immediately adjacent to the prostate. These tissues get the highest dose compared to tissues far from the prostate. Often these will be worst while getting the radiation and shortly thereafter and are called acute side effects. Some of these side effects of radiation do not happen immediately, but may develop months or even years after radiation therapy is completed and are delayed side effects. Overall, the most common side effects after radiation include urinary and bowel problems, erectile dysfunction, and fatigue. We'll talk more about these complications after I talk about surgery so we can compare both of them together. All right, so next on our item, let's talk about the other treatment option for prostate cancer, surgery. Per the NCCN guidelines, surgery is listed as an option for men who are not on active surveillance, who have at least 10 years of life expectancy, where the cancer is expected to be able to be removed completely and have no condition or risk factor that would make surgery contraindicated. Surgery for prostate cancer involves removing the entire prostate. In addition to removing the prostate, we remove the small gland attached to the back of the prostate called the seminal vesicles. The bladder is then sewn to the urethra down below. In some men, depending on the risk of lymph node involvement, based off of preoperative risk stratification, we may also offer them a lymph node dissection to sample the lymph nodes in the pelvis. In prostate cancer, removing the lymph nodes has not been shown to improve cancer outcomes, but does give us additional staging information to know if they're involved. All right, surgery for prostate cancer can be performed in an open fashion with a single large incision, or minimally invasive approach with laparoscopically or robotically. In the United States, since 2008, the majority of prostatectomies performed have been done robotically. By 2017, less than 1,000 prostatectomy procedures per year were performed in an open fashion, and that number continues to precipitously decline over time. Today, you're hard-pressed to find someone who's had an open prostatectomy in the last several years. And the reason for that is robotic surgery has been shown consistently to have less blood loss, shorter hospital stays, and lower postoperative pain for patients in clinical trials. Cancer outcomes have also been shown to be similar between robotic and open surgery. In terms of postoperative stay, in our own institution, over a 3-year period, we had nearly 100% of our robotic prostatectomy patients discharged on the same day of surgery. Robotic surgery itself can be performed with a single port system, or more standardly, with a multiple port approach. The patient generally wakes up from surgery with a urethral catheter for postoperative drainage for a period of time. In our practice, usually the catheter is in place for about 7 days. After surgery, there are not many restrictions. Most physicians suggest a time period of no heavy lifting to avoid hernia formation at the site of the incisions. For my patients, I often recommend 6 weeks of no lifting more than 20 pounds. All right, risks. When we talk about prostate cancer, it's important to note that all treatments have potential risks, and there are some differences between the treatment options. Generally, the risks of surgery are more immediate than the risks of radiation. The potential for injury is at the time of surgery and not delayed at some point in the future. Additionally, with surgery, side effects tend to improve over time as patients heal. So the side effects 1 month after surgery are different than when you compare them 1 year or 10 years later. The main side effects of any treatment for prostate cancer include the risk of urinary incontinence and erectile dysfunction. Most men after surgery have some stress incontinence that improves over time. Studies show that at 1 year after surgery, about 5 to 10% of men still experience stress incontinence that requires the use of at least a pad a day. Now, if that happens to you, it's 100% of the time. So it still can happen even though it's a small percentage. And of those patients, many of them will go off to getting other surgeries to treat the incontinence, and there are surgeries to help that. Erectile dysfunction is common early after surgery as well, and generally improves over time. As we'll see later, the risks for ED are similar from surgery to radiation. The risks are generally equal and relate more to your preoperative erectile function. Additional risks of a radical prostatectomy that are different from radiation include the risk of damaging surrounding structures or the risk of anesthesia at the time of the operation. Surgery-specific risks include risk of bleeding with the need for a blood transfusion rate, rare in modern surgery, infection, pain, damage to surrounding vessels, including blood vessels, nerves, bowel, lymphocyte formation, hernia, and need for additional procedures. There are rare risks with any surgical procedure that requires general anesthesia, including blood clots, pulmonary embolism, heart attack, stroke, and even death. But these are incredibly rare with modern surgery. All right, that is a lot of information about treatment options. Looking at them alone, sometimes it can be difficult to make a decision about one or the other. And I think it's important to compare the two together. All right, so let's compare surgery with radiation for localized prostate cancer. The first important thing to note when comparing these two is that there are very few head-to-head clinical trials comparing surgery to radiation therapy. The majority of trials looked at surgery patients or looked at radiation patients and compared them over time. Of these, we have many that compare long-term outcomes of surgery and radiation therapy, but few that compare head-to-head. It's also important to note that in terms of cancer control, surgery and radiation have different definitions of failure. After surgery, clinical trials call surgery a failure if the PSA rises above 0.2. For radiation, clinical trials generally call the definition of failure a PSA of a rise of 2.0 above the low point. So these are measured quite differently when we talk about a biochemical failure. That being said, how do cancer results compare between the two? Overall, the rates of cancer control appear to be quite similar for prostate cancer. Again, without many head-to-head trials, it's difficult to compare exactly, but what we can say is that they appear similar in terms of efficacy. So, one review found that both surgery and radiation therapy improved overall survival and decreased the chance of a PSA recurrence compared to watchful waiting. For most men, I tell them that both options are good options. Choose the option that makes the most sense to you. All right, so let's compare side effects between surgery and radiation. First up front, surgery will have risks that tend to happen again at the time of surgery and improve over time. Radiation is going to be backwards. You may have a flare of symptoms while you're getting radiation therapy, and then they go away, but may increase over time as the years go by. Those long-term risks of radiation therapy in clinical trials have been shown to get worse at 10 years compared to 5 years and 15 years compared to 10 years. As I mentioned before, surgery has specific risks that radiation does not have. Because of the nature of surgery, there are risks of anesthesia and risks of damaging surrounding organs or bleeding. And although in modern prostatectomies these are quite rare, in less than 1%, they can happen. All right, so the three most prominent risks we should look at when comparing surgery and radiation are erectile function, urinary incontinence, and rectal side effects. In terms of side effects, erectile dysfunction appears to be worse immediately following surgery but improves over time. And so if we look at 5 or 10 years following treatment, the rates of erectile dysfunction are similar as long as a nerve-sparing procedure was performed at the time of surgery. Recovery of erectile function in surgery is related directly to the degree of preservation of those nerves, the age of the patient, and the preoperative erectile function. In terms of urinary incontinence rates are higher in patients who undergo surgery compared to radiation therapy overall. Initially, I tell surgical patients that they should typically expect some postoperative stress incontinence. This type of incontinence includes leaking urine with increased abdominal pressure on the bladder, such as abdominal straining, lifting, coughing, jumping, or sometimes walking. This does improve significantly over time, especially in that first year after surgery. And studies routinely show about a 5 to 10% of rate of incontinence at 1 year of men that require a pad. In one study, although the rates of incontinence were higher at 2 or 5 years following treatment with surgery compared to radiation, at 15 years, the risks of incontinence were similar between the two groups. Why does surgery have stress incontinence? For most men, the prostate itself is obstructive. As we age, that prostate grows and the bladder has to work harder and harder to empty. Men do not typically have to use that sphincter muscle or even think about it when they're leaking. They don't have to think about it when coughing, laughing, or sneezing. The only time they're using that sphincter muscle is when they're trying to stop their urinary stream while urinating. When we perform surgery, that prostate, that obstruction, is removed. That external sphincter is rarely injured during surgery. So the issue is when that prostate's removed, that muscle, the sphincter, has to work harder than it had done previously. And men have to learn to use it properly. And because they haven't used it in the past, it takes some time to learn. Additionally, it appears that the bladder neck itself has a component of bladder control, and as surgeries are performed to spare the bladder neck, have sooner return to continence in men that have a bladder neck reconstruction, and men with a very large prostate at the time of surgery may have higher incontinence rates. Radiation overall does not remove the prostate, and because of that, does not have the same effect. Generally speaking, the incontinence that appears after radiation therapy is due to what we call storage urinary symptoms. The bladder after radiation loses elasticity and capacity and becomes overactive. Men may develop urgency incontinence and leak urine because they can't make it to the restroom in time, which is quite different from the incontinence with surgery. In terms of urinary symptoms, for men who have obstructive urinary symptoms from their prostate of slow flow, frequency, urgency, or difficulty starting their stream prior to treatment, surgery typically relieves those symptoms as well. Radiation itself damages the cells and causes the prostate to shrink, but does not open or remove the prostate, so it's not going to remove those obstructive symptoms. If those symptoms are present and you're on the fence between the two options, surgery might be a better option for you. If you want to proceed with radiation, that can work as well, but you may want to consider a procedure to open the prostate, such as a TURP, UroLift, or Rezum procedure prior to radiation therapy to relieve the obstruction before getting radiation. Because after radiation, those symptoms will often get worse, and procedures to open that channel have higher complication rates after radiation because those tissues in the operating field have had DNA damage and are less healthy and have a harder time healing. All right, on to rectal side effects. Rectal side effects are higher with radiation compared to surgery. The reason is that radiation has the effect of increasing bowel frequency, increasing the risk of fecal incontinence, and bleeding compared to surgery. Additionally, several studies have shown that there's an increase of what we call a secondary malignancy, or developing a cancer in a different area that's been treated due to radiation. Studies have conflicting results about this. One review from the BMJ found that estimates for absolute increased risk of bladder, rectal, or colon cancer range from 0.1 to 0.3% in low studies, and in the high studies, 1.2 to 4.2% risk. All right. Again, as I mentioned previously, a note about radiation side effects is that the delayed side effect risks and urinary symptoms seem to increase as time goes on from radiation, as seen here in this study. In another study, they also confirmed a higher risk of urinary toxicity the farther out from initial treatment of radiation therapy. This is especially pronounced for men who have more acute symptoms early in their radiation treatment, where they had double the risk of long-term side effects. I point this out here as this might be one reason to more strongly consider surgery compared to radiation in younger patients. If the side effects get progressively worse at 15 or 20 years out from surgery, it's not as big of a concern for a 70-year-old, but for a 50-year-old patient, you have that life expectancy, and it might be a reason to lean towards surgery. One other thing to mention when we talk about comparing the two is that we should also talk about what we need to do if there's a local recurrence of prostate cancer after surgery or radiation. This would be expected to happen about equal rates between the two options. So if you picked surgery or radiation therapy and there is a recurrence of prostate cancer, how do we handle it? Well, if you've had surgery, radiation afterwards can be performed without significant issue. However, after radiation treatment, the prostate and the areas around the prostate have had some permanent DNA damage. So surgery in this setting, it can be done, but there are a few centers that do this, and it's known to have a very high complication risk, high postoperative erectile dysfunction and incontinence, and because of this, it's not recommended as the first line. There are, however, other alternatives, and if there's a recurrence after radiation, those include cryotherapy, HIFU or brachytherapy, or additional radiation therapy. But all these procedures done after radiation therapy have increased risk compared to someone who hasn't had radiation therapy. And because of that, some men that have a localized recurrence after radiation therapy may not get any treatment or may move on to things such as hormonal therapy rather than treating the prostate itself. All right, so that's a lot. Next, I should have a brief mention of non-standard treatments for prostate cancer. So in the last few years, many therapies have been studied as alternative options comparing against surgery or radiation. The goal of these other treatment options is to reduce the risks and side effects of treatment, but try to maintain cancer control. At this time, the National Comprehensive Cancer Network does not recommend these therapies as routine primary therapy, as they don't have sufficient long-term data compared to surgery or radiation. What are these options? These options include cryotherapy, high-intensity frequency ultrasound or HIFU, focal laser ablation, targeted photodynamic therapy. Essentially, these are functioning similarly. They're killing parts of the prostate without removing the whole prostate. Many of these studies have follow-up patients of data at 2 and 5 years, and we don't have the 10, 15, and 20-year follow-up data that we have for surgery and radiation therapy. So, if you're going to get one of these treatments, we recommend that you do so in the context of a clinical trial so we can learn and see what the long-term results are for patients. All right, so that was a lot to cover in one video. There are many more intricacies of each option, but hopefully this gave you some information to start helping you make a decision and come up with questions about how to treat your prostate cancer and bring these up with your urologist or oncologist. If you have any questions for me, put them in the comments below and I'll try to get to them. Again, this video today is not direct medical advice, but educational in nature. And if you have direct medical questions, you should talk with your physician. All right, again, Dan Reznicek from Pacific Northwest Urology, and thanks for watching this video today on treatment options for localized prostate cancer.